Great. So let us start. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hello, everybody, and welcome to this very distinguished session in To the Wonderland Cornea series from Sinjab Academy. And the topic today is the DMEK complications, how to prevent and manage. Actually, we are very lucky today to have 3 stars in the sky of the cornea, the teacher of the teachers, Professor Christopher Liu from the UK, Professor Goueda from Egypt, and Mr. Ahmad Bardan, Shalabi Bardan from Egypt, working in the UK. If you allow me just to, of course, none of them needs to be introduced because they are very well known, but this is the protocol. So Professor Liu is a consultant of external eye disease of cornea and cataract in Brighton at the Sussex Eye Hospital. He is a world-leading expert in the osteodonto keratoprosthesis. He also serves as an honorary clinical professor and undergraduate ophthalmology lead for the Brighton and Sussex University. He is the past president of the Medical Contact Lens and Ocular Surface Association, British Society of Refractive Surgery, Southern Ophthalmological Society, and he is the current honorary treasurer of the Royal College of Ophthalmologists and president of Brighton and Sussex Medico Chirurgical Society. Of course, the bio is very long, so we'll take the whole session just to talk about him and his achievements. And of course, I would like to welcome the 2 speakers, Professor Goueda, Mohamed Bahgat Goueda from Egypt. He is a consultant cornea and external eye disease in Alexandria Main University, as well as assistant professor in Faculty of Medicine, Alexandria University. He has over 50 presentations in national and international conferences and over 20 publications in peer-reviewed journals. He is one of the pioneers in Egypt in the field of lamellar keratoplasty, DALK, and DMEK. He established the first national osteodonto keratoprosthesis service in Egypt after receiving training in Sussex Eye Hospital and helped many desperate patients with end-stage corneal blindness. He is regular contributor at many courses and congresses in Egypt and worldwide. And of course, I'd like to welcome the one who assisted me in writing the book, if you remember, Ahmad, the customized laser vision correction, the chapter of Professor Mohamed Shafiq Shaheen. I think he is your teacher in Alexandria. Yeah, it was a great pleasure that we had you in the book. He is a cornea and refractive surgery consultant at Leeds Teaching Hospitals, lecturer at Alexandria University and Leeds University, Fellow of the Royal College of Ophthalmologists, London, Fellow of the Royal College of Surgeons of Edinburgh. By the way, I'm traveling to Edinburgh after tomorrow for the examinations because I am one of the board examiners. He has as well certificate of laser and refractive surgery, and he got his PhD from Alexandria University. So I would like to welcome you all and thank you very much for accepting the invitation to talk about this very hot topic and to have our great teacher, Christopher Liu, as a moderator for this session. So let us start. Who will start? Professor Goueda or Ahmed?
So
may I start with a brief introduction?
Yes, please, Christopher.
Yes, please.
Thank you. And then I may have to excuse myself and then join you in discussions when the 2 talks are finished. So firstly, welcome to all the delegates, both online now and later on. and DMEK, decimase membrane endothelial keratoplasty, is a wonderful operation because you are just removing the diseased endothelium and replacing that. And it gives very, very good quality vision. And for a patient who's got a DZEK or DZEK in one eye and a DMEK in other eye, they always prefer the DMEK eye, even if the visual acuity is slightly lower. Such is the quality of the vision. So why is everybody not doing it? Because it is more difficult to do, and you're struggling with sometimes a cloudy cornea, and also with preparation of the DMEK graft. With younger patients in particular, it curls up very tightly and is difficult to open. Whereas in diabetic patients, there may be a higher chance of tearing the DMEK preparation. However, of course, help is at hand, and there are some major eye banks which actually prepare the graft for you and will send the disc of tissue ready for you to transplant. Now, once you've transplanted, then also it is difficult because you are trying to manipulate the graft once it's inside the eye, trying to touch it as little as possible. And if you do have to touch it from the side where there is no endothelium, and doing it as quickly as possible and reducing the risk of any fibrin or bleeding, because then that makes the DMEK not stick. So you need to be fast as well, and making use of currents and tapping from the outside, and also controlling the anterior chamber, which must be deep enough when you want to change the position or to flip it upside down to the correct orientation if it's gone upside down. But on the other hand, if you want to capture the unfolding that you have done, you need to keep the chamber shallow. So what you've gained from unfolding does not allow it to be refolded. So these are all the challenges, and you're going to hear from two maestros as to how to prevent getting a problem, and once you have a problem, how to get out of it. I will join you for discussions later, and Mohamed, perhaps you can give me a call when Ahmed is about to finish, and I'll join you for discussions. I'm so sorry. I inadvertently allowed myself to be double booked, but I will be back with you for discussions. Thank you.
Thank you, Christopher. Thank you very much. Okay, so you will start, Mohamed, first.
Yes, okay, I'll share my screen now.
Yes, we can see your screen. Thank you very much. You can start.
Okay, great. So, hello, everybody. It's a pleasure to be with you today, and thanks, Professor Mazen, for his kind invitation. So today we are going to talk about complications of DMEK. It's a very long topic, but I will try, me and my friend Ahmad Shalabi, try to cover the most important topics in DMEK. Regarding the intraoperative complications of DMEK, complication may occur during graft injections, during unfolding, or during air injections. I'm going to discuss in my presentation the complication during graft injection and during air injection. And Ahmad Shalabi will discuss the complication during unfolding and some post-operative complication. So before talking about the complication during graft injection, we must define first what is the meaning of safe tissue injection. To have a safe injection of your DMEK graft, your injector or your system of injection should be watertight, and the pipette should occlude the main wound. Delivery of the graft should be done by short staccato depressions on the plunger of the syringe. This probably will result in slow delivery of the graft and should be accompanied by intermittent decompression of the anterior chamber so that the intraocular pressure does not rise and result in extrusion of the graft during removing the injector. Removal of the injector should be done cautiously to prevent extrusion of the graft. Of course, the first thing in injection is to make sure that injection is in the proper orientation. You must observe the injector or look at the tissues inside the injector and make sure that this triangle or rhomboid is present. You may rotate the pipette to have this appearance to make sure that the delivery of the graft is in the proper direction, in the proper orientation. So now I'm introducing the pipette inside the wound, and I'm doing some rotation of the pipette to make sure the graft is in the proper orientation. And then pushing on the plunger to have a safe tissue injection. So these are examples of safe tissue injection. The pipette should be inside the anterior chamber, totally inside the wound, and injection should be done very slowly, resulting in slow delivery of the graft in the anterior chamber. So what about fast injection? What will happen if you do fast injection? So these are examples of fast injections. This may occur because of sudden pressure on the plunger, uncontrolled pressure on the plunger, such as in this case. Fast tissue injection will result in loss of orientation. You adjusted before injection. You may lose the graft under the iris, or it may be trapped in the angle, or you may have unusual folding pattern of the graft, such as the formation of an origami, which is considered scrambled form of the graft and may be an issue during unfolding. Before injecting the graft, you must make sure that the injector does not have any bubbles and the anterior chamber is empty of bubbles. Presence of bubble will lead to loss of orientation of the graft, the formation of an origami, or even sometimes the extrusion of the graft during removal of the injector. Also, during injection, you may have incomplete graft delivery. This may happen if the graft is too large, if the anterior chamber is shallow, and should be avoided by wide-to-wide measurement or putting an AC maintainer. This can be managed by just irrigation on the main wound. You can reintroduce the graft in the anterior chamber. Sometimes irrigation does not work, and you may have to reintroduce the graft using a spatula or a cannula. So this is a case of shallow AC, and the path of the graft is obstructed by the iris, resulting in incomplete delivery. Unfortunately, irrigation did not work, and you have to introduce it using a cannula or a spatula. This is one of my early cases. about more than 10 years ago, there were no available injectors in the market, and I had to custom make a glass pipette so that I can inject my graft. Unfortunately, the port of the pipette was not fitting inside the wound. So as we can see, this may result in failed delivery of the graft in the anterior chamber. This also may occur with the available injectors in the market if the incision is too small or the injector is too large. To prevent this, you should introduce the pipette into the wound before loading the graft. And you must make sure that the pipette is fitting well in the wound. And the injector should be completely inside the anterior chamber before delivery of the graft. You cannot manage the DMEK graft similar to the IOL and do a wound-assisted injection. This cannot work. In DMEK, the pipette should be totally inside the anterior chamber and fitting properly in the wound. So this is a case of phakic eyes. I was introducing the graft, but it was not fitting well in the wound. And look what happened while I am injecting. So in such cases, you should remove the graft, reload it in the wound. And in such case, I just did angulation of my graft so that the pipette is fitting well in the wound and the pipette is away from the pupil because this is a phakic eye, and reintroduced the graft inside the anterior chamber. This may also occur if the anterior chamber is shallow or the intraocular pressure inside the intraocular pressure is high, or may occur if you withdraw the pipette suddenly. So during injection, you may inject the graft behind the iris. May occur due to faulty injection if the pupil is dilated or disorganized anterior chamber, such as in this case. So the pipette is introduced properly in the anterior chamber, but look what happened while I am removing the graft. While I'm removing the injector, the graft went behind the iris. If the graft escaped behind the iris, do not try to reposit it using gushes of fluid, because this may make things worse, and this should be, unfortunately, should be reposited using a spatula or a cannula, although it will be a bit traumatizing to the graft. So to summarize the tips during injection, you should remove all viscoelastic, remove all bubbles from the anterior chambers and from the injector. The tip of the injector should be inside the anterior chamber. If the AC is shallow, use the anterior chamber maintainer and stop irrigation once the graft is entering the anterior chamber. You may ask your assistant to hold the speculum away from the globe to decrease the pressure. So the second part of my talk is the complications during air injections. And before discussing the complication, I should give a note about the air strategies in DMEK. We all know that the rationale of air strategies is to fix the graft in the early post-operative period to manage detached area. There are two protocols for air management in DMEK, either the peripheral iridectomy protocol or the PI-less protocol. And there are two tamponading agents, which are the air or SF6 20%. The inferior PI can be done preoperatively using gag if the media permits, or you can do it using a cutter or manually. While performing the PI, you may have some complication such as bleeding, fibrin, or the iodotomy may be partial thickness, or it may be large or small in size. So this is the manual iodotomy, and we here find the presence of blood as a complication. This is a phakic eye, and we are doing the iodotomy using the cutter from above the iris, or instead of phakic eye, you may do it using the cutter behind the iris. The most important is you must make sure that the iodotomy is full thickness. This can be done by introducing a spatula to make sure that the iris is cut full thickness. The advantages of the PI-less protocol is that it avoids possible blood or fibrin, but it needs dilating eye drops. It is done by complete AC fill at the end of the surgery, keeping the patient in the OR in the supine position, then releasing some of the air after 1 hour. Slit lamp examination is mandatory before patient discharge, whether in the PI protocol or the PI-less protocol, and air should be above the inferior edge of the pupil or above the peripheral iodotomy. Tips during air injection is to make sure first that the anterior chamber is formed. You should introduce a 27 gauge cannula mounted on a tuberculin syringe through the paracentesis. Advance the cannula till it reaches the center of the cornea. Inject a small air bubble, then slowly increase the size till complete or partial AC fill. And finally, withdraw the cannula gently. So what mishaps may happen during air injection? Complication during injection usually occurs when you feel that everything is done and that your surgery is complete, but you may find some surprises during air injection. So as we can see, this case is nearly completed. The graft is nicely unfolded, good centration, and only a small part is still folded, which I'm going to complete it using air injection. So I'm now injecting the air, but look what happened. Some air bubbles escaped prematurely from the syringe and resulted in decentration of the graft. And I have to repeat some steps of the surgery, re-unfolding the graft, centering the graft, and finally injecting the air in the anterior chamber. So why did this happen? Sometimes the syringe, you are not familiar with the syringe you are using. Sometimes you are introducing the syringe with your thumb, with your index finger on the plunger, so that you just introduce it and press on the plunger. So you shouldn't do this, and you shouldn't press on the plunger or put your thumb or index finger on the plunger except after going inside the anterior chamber. And try to use high quality syringes. Bleeding may occur also during air injection. I finished everything. Now I'm introducing the cannula to the center. I find some resistant injected air, and now I found bleeding, which I don't know the source, really the source of bleeding which happened. And the blood started to trickle between the graft and the stroma. I'm trying to evacuate the blood, but it is not working. I'm introducing a spatula between the graft and the stoma. I don't know if this is correct or not, but I don't have anything to do. Realized that nothing more can be done except injecting air and finishing the surgery as such. Luckily, this patient did not suffer from any complication. I was expecting that this patient may need rebubbling or may suffer from severe interface his. There was only very mild interface his did not affect the visual. Complication, the third complication which may occur during air injection usually happens in eye with either complete vitrectomy or anterior vitrectomy. This is a vitrectomized eye, and after finishing everything and unfolding the graft, I injected air in the anterior chamber and found something strange, that the air is decreasing in size and the intraocular lens started to be decentered. Trying to inject more air, but it comes out from the anterior chamber. Finally, a small air bubble is remaining. I'm trying to just keep the IOL away from my graft. Finally, I realized that the problem is the escape of the air in the vitreous cavity. I introduced a cannula through the PI in the vitreous cavity, started to remove the escaped air from the vitreous cavity. Things started to be better. Then I started to fill the vitreous cavity with fluid. And at that time, I felt that the AC now becoming deeper and can inject my air bubble safely. So in vitrectomized eye, there are certain precautions to be done to avoid escape of the air. And for beginners, it's better to not to begin with such cases. So air also may escape behind the iris. This is a case of DALK referred from one of my colleagues. He told me that air is behind the iris, the intraocular pressure is high. I don't know what to do for this patient. I told him you should evacuate the air, and he asked me to do this. So he referred the case to me, and I found the AC shallow, the air is behind the iris, and the intraocular pressure is high. I entered the OR. The patient was inside the OR and under general anesthesia and started to evacuate the air. It was really a difficult procedure in such phakic patients, and taking the peripheral anterior synechia, which occurred. And finally, I had a very small air bubble. This also may occur in DMEK, and you must evacuate the air immediately if the air escaped behind the iris. It will not leave the posterior chamber spontaneously. It should be evacuated. So to prevent the air escape in vitrectomized eye, you should insert the pars plana infusion in vitrectomized eye, avoid complete AC fill, inject air behind the bubble to fill the vitreous cavity. So this is a case of vitrectomized eye. After I finished everything, I started to inject air behind the bubble to fill the vitreous cavity. If the vitreous cavity is full of fluid, the air will not escape to it. But if you are having an empty vitreous cavity, of course, it will all the air will go into the vitreous in the early post-operative period. Also, you should avoid complete AC fill, because if pressure is high into your chamber and you are having a low pressure in the vitreous cavity, usually air will pass from the area of high pressure to the area of low pressure, and the air will go into the vitreous cavity. Other complications of air injection are the pupillar block and the Oert-Savalia syndrome, and this should be avoided by slit lamp examination 1 hour after surgery. you should make sure that the air bubble should be above the PI or above the lower pupillary border if no PI. And this is the appearance of the post-operative period. The AC should be half fill or 2/3 fill if you are having a good PI. So this is the end of my presentation, and we can discuss any questions after Ahmad Shalabi finishes his talk. Now I'd like to invite my brother and friend Ahmad Shalabi to continue the complications of DMEK.
Thank you very much, Professor Guida, for this nice presentation. And yes, better to keep the discussion to the end. So now, Dr. Ahmad Shalabi, to start your presentation, please.
Yeah, just a second. Well, thank you, Dr. Guida. Very nice presentation. I always learn from your lectures, from the nice videos that you present to us. So very nice. Let me just.
Thank you.
Okay, so can you see my slides now?
Yes.
Okay, so as Dr. Guida mentioned, well, actually, Dr. Mazen, Professor Guida is now a professor, so I think the bio is not up to date, saying he's associate professor. So the good news is that he's now been promoted to a professor in Alexandria University. So congratulations.
Congratulations.
Thank you.
So I'm going to talk about the other side of the complications, mainly during the procedure, during unfolding, and the early post-operative and the late post-operative complications. As Dr. Guida mentioned, and as Professor Liu highlighted, DMEK it requires a steep learning curve. So the difficulty or the tricky part of DMEK learning is to acquire this repetitive approach or standardized approach so that you can minimize the complications and be able to expect it and prevent it before the complications happen. More or less similar to all other eye surgeries like cataract surgery, like refractive surgery, we tend to aim to minimize or prevent complications as much as possible. And that can only be acquired through the learning curve or more and more practice, more and more education. So I have no financial interest in any of the contents of the slides. All the surgical videos that I will show belong to us, the group, either my videos or Professor Liu or maybe Mohammed's videos. So the main complications that I'm going to talk about are the unfolding complications during the surgery itself. So the three main complications is, in the past, we used to get any age donor. So 20s, 30s, 40s, and the younger the donor, the more tight the scroll. And that, of course, introduced a difficulty during the procedure. The second one will be the DMEK orientation. So I'm going to give some tips about how to try and adjust this and avoid upside down DMEK, and also how to deal with it when you diagnose upside down DMEK. And the last thing during the unfolding is if you get bleeding or a release of iris pigment or fibrin, how to deal with that. So this is just an example of, in the old days, we used to get oldish, youngish donors. So that was a graft, a donor of 22-year-old. And as you can see here, after introduction of the graft, it's very tight. Luckily now the eye banks are familiar with the fact that DMEK would be better and easier with an older donor. So they send us more senior, more old donor tissue. As you can see, it scrolls like a carpet at the edge and is very difficult to open with the normal, even with the use of a cannula. Trying to open the edge is not easy. So you have to employ other techniques like a small bubble above the graft and trying to expand this, shallow the AC. Every time we achieve unfolding of the edge, we try to increase the size of the bubble until it unfolds the graft completely. And after that, we will have to take this bubble out, the one above the graft, and inject a bubble underneath the graft. That happens when the donor is, I would say, like 40 or 45 year or less. With the older donors, we luckily get easier to unfold tissues. Now, the second topic is the DMEK orientation. So just briefly, I am familiar with the previous DMEK course with Dr. Mazen Sinjab, run by Professor Dr. Tariq Katamish. So he has very thoroughly covered the standard technique of DMEKs. So I would expect the audience to be familiar with the DMEK preparation techniques, with the different methods of the standard technique. So I'm just going to point to the main things that would affect DMEK orientation. So in general, these are the ways that you can know whether your DMEK is in the correct orientation or upside down. Either you watch the graft edge, the way it scrolls, and as we know, it's meant to scroll towards the decimate side. So essentially, by just observing, if you're not using any marking technique, by just observing the way the graft edge scroll, or confirming that with the Montsuri sign, going with a cannula inside and trying to see whether the graft is scrolling upwards or downwards, you can get an idea about the way it scrolls. This is the Montsuri sign, so going inside the scroll with a spatula, iris repositor, or a cannula, and watching that spatula hiding underneath the fold of the DMEK would confirm that it is in the correct orientation. Now, we have published a paper on upside down DMEK, and one of the observations we noticed is if you're late towards the surgery, the end of the surgery, and the graft has lost its blue color, and especially in the dark colored iris, like iridis like this one, you may actually be deceived, because if you're going to try and test for Montsuri sign, if your cannula or iris repositor is inadvertently going underneath, not above the graft, then you will get a false positive Montsuri sign. You will be deceived, essentially, thinking that you've gone through above and then gone inside the fold, but actually you're underneath the graft and it's upside down like this one. So you have to be very cautious if you're not using a marking technique. Now, I'm going to show two of the marking techniques that I used throughout my learning curve. This was the peripheral irregular mark, or the fish fin, or the triangle, or half arrowhead. Essentially, you just do standard peeling. I edited the video heavily just to show this part. After refining the part, the 8mm or 8.25, we cut this triangle or a half arrowhead, and this is pointing anti-clockwise. And then essentially, we will observe that inside the eye and make sure that it is actually pointing clockwise. As you will see here in that video, towards the end of the surgery. So it's just routine DMEK, unfolding as usual. And then I'm going to go towards the end of it to show you you see now this fish fin or half arrow is pointing towards clockwise. So that confirms that it's in the correct orientation. And this is one of the signs that you can rely upon if you want an orientation mark. The problem with this is, as you saw, when we cut this angle, encroach on the stroma of the donor tissue. So it would make it less possible to use that stroma for another patient, for DALC, for example. This is the other one that I use routinely now. I mean, in the UK, we're not allowed to split the tissue between two recipients anyway. So we use the full tissue for one single patient. And this is why I don't mind marking all the DMEKs. So the one I use now is the F mark. After peeling 2/3, we use a small trifine, like 3mm, to cut this little window towards the peripheral side of the graft, and then put the decimates back in place. And then we will put the whole cornea upside down. So we will be accessing from the epithelial side now, removing that window, drying, and then using an F stamp to stamp from the outer side. And essentially, what we're looking for is a correct side F. If the F looks the opposite direction of the correct F, then it's upside down. So this is from the endothelial side. After cutting the size that we are going to use, 8 or 8.25, we'll just peel that. And then I'm going to show you again towards the end after loading. As Mohamed mentioned, one of the very important things during DMEK is to watch the scroll orientation during the injector. So I keep watching that as it goes, and I adjust and rotate my hand to make sure it goes inside the eye in the correct orientation, because that saves you a lot of time. This was confirming with the spatula, the Montsuri sign as well. So even though I use F mark, I just try to employ more than one method. That was one of our fellows doing it. So the tapping and the unfolding wasn't as straightforward, and I may have used my other hand from the side to help him just get it in the correct centration and in the correct unfolding way. And the F was actually around this side here. It may not be very obvious in the video, but under the slit, the microscope, and also post-operatively on the slit lamp, you can easily tell that the F is showing, it's here, showing the correct orientation. So these are the methods. Before that, we were using no marking and just relying upon looking at the edge, the way it scrolls. This is one of the deceiving cases. So essentially, I always say, if you have a question, if you have a doubt about it, and you haven't used an orientation mark, then just think it's upside down, because when it's in the correct, or like this one, for example, the edge is folding downwards. So it is actually upside down. And usually when it's upside down, it opens up and unfolds quite easily, surprisingly. And then you will be thinking, okay, I'm done with it, but actually it's in the wrong orientation. So when in doubt, it's upside down. And if you want more information about managing upside down DMEK, there is our publication, myself, Mohamed, and Professor Hisham El-Gouini from Egypt, and Professor Liu, which is available open access. This is another video just to show you the same concept. So essentially, this is a tight scroll. So our method to open that is usually to go inside and maybe use an air bubble to inject. So watch, I want to stop here for a second. Watch the cannula. You can easily tell that the cannula is going underneath, not above the DMEK scroll. And this bubble went inside the scroll, but from underneath. So essentially, it opened the graft, but it is in the upside orientation. Again, I'm going to aspirate the bubble now from underneath it, and you can see the edge is scrolling down. Every time you tap, you can see that it's scrolling down. So this is upside down, and this has to be corrected before you put the air in. This was one of the cases that had non-sticking DMEK detachment. And we thought, you know, we go back to review the original video, and we figured out that it was upside down. So because it already started to stick partially, so we had to go back. This was actually one of Professor Liu's videos. So he had to make this vent incision to try and encourage the graft to completely detach so that it becomes loose in the anterior chamber, as you can see here. But of course, this was after heavy editing of the video. And then it became loose, and now we're using Montsuri sign because the graft is not very stained, to open it up in the anterior chamber and then put it back in. And we showed in our paper the outcomes of reorienting the upside down DMEK compared to getting a new tissue and doing a fresh DMEK. Now, this is one of the complications that is very, very bad for DMEK surgeons, especially for starting DMEK surgeons, which is while you're trying to tap and unfold, the eye starts to release fibrin and pigment. And then when you combine that with loss of the blue color throughout the procedure, the fibrin will just make it, and the pigment will make it very difficult to see the graft. And plus the fibrin itself can actually act as a natural glue. And then you will find that the graft is sticking to the iris, or not moving, or sticking in the angle. So this is one of the very tricky complications here. Now, a lot of my juniors ask how to avoid that or how to manage. So essentially, you have to use the standardized technique. As Professor Liu mentioned, you have to be as quick, as slick as possible, because when you get it right in the fastest way possible, then you just win the procedure. You put the air bubble and you go home happy. So if you take longer time, especially if the case is complex, like for example, if a patient, I saw cases before of iridocorneal endothelial syndrome, those eyes are already pro-inflammatory, so high risk of developing fibrin and pigment release and maybe bleeding as well. So these cases, I would recommend doing it under GA, because the increase in pressure, like this case, you can see that it was done up under subtenon. And I noticed that doing subtenon increases the chances of getting this fibrin release. There are theories behind that. It may be that we increase the pressure from behind, we change the pressure around the veins around the eye. Anyway, it's going to be more relaxed, better for you, better for the patient. If you're expecting that this case would be a difficult case, firstly, to refer to a senior surgeon so they can do it the shortest time possible, do it under general anesthetic. What I do now, if I'm expecting it to be a complex case that would lead to fibrin release or bleeding or pigment release, I get the pharmacy to prepare Altiplase, which is a fibrinolytic. You can wash the AC with that to reduce the chances of the graft getting stuck in fibrin. The other thing that I sometimes consider to try and avoid, let's say if there is bleeding, I try to give it time, put an air bubble in, wait for the bleeding and the fibrin to settle before I introduce the graft in. So again, prevention is better than getting stuck with the graft inside the eye and then having the bleeding or the fibrin. The other thing that I do now as a routine is to avoid doing, as much as possible, avoid doing the intraoperative PI, because dealing with the iris is one reason that may cause bleeding and fibrin and pigment release. So I do preoperative YAG laser PI for all of my cases now, unless the view is very bad, and then you need to do an intraoperative PI. And there are some precautions. So for example, do it as early as possible during the procedure to let enough time for the bleeding to stop and the fibrin release to be washed before you introduce the graft in. Now, this is another case that I did recently. So essentially, these are the kind of complex eyes that you would try to stay away from if you are beginning. So this is an aphakic eye corrected previously with an iris clip lens. I had 2 failed PKs, and the decision was to do DMEK under the PK to correct the graft failure. You can see that there are 3 large PIs around done previously as part of the old PK and also the iris clip lens that was done. So essentially, the difficulty here was that this lens artisan was loose. One of the haptics was not grasping enough iris tissue, so it was like de-incavated from one haptic. So after doing this matorexis and testing for the presence of vitreous in the AC with Kinalog, we started to notice that the lens is loose. And then the difficulty here was to re-enclavate that without opening the eye large wound. My choice was to leave the lens. So that's after a few trials. And you can see this patient is on antiplatelets. So the iris started to bleed. We managed after a few attempts to re-enclavate this haptic using a microforceps and a Sinjab hook to grasp some of the iris tissue within the claw of the lens. So as you will see now, we'll give it time for the bleeding to stop, but it will keep trickling. But again, I just be patient. I give it time. I put some air bubbles and wait for the blood to stop as much as possible, or at least be a very slow trickle before I introduce the DMEK graft. My preference in those cases, I know that other colleagues may recommend moving the IOL to the posterior chamber. We try, in the UK, we try to avoid getting involved with the posterior segment as much as possible. And my VR colleagues would be like, okay, if you wanted to put it in the posterior segment, you should have got us involved. So I just decided to re-enclavate it, leave it as it is, waited for the blood to settle, which is my advice. If you get something like this, I kept putting air bubble and giving it time. And you will notice every time we aspirate the air and put some BSS in, you will see trickling of blood still. So I just waited until the blood was sort of manageable. In this step here, I was holding the graft in one hand and actually used the IA as the last thing to just make sure I wash it as much as possible before I introduce the graft in. So for that kind of thing, for that kind of procedure, your DMEK has to be as slick as possible, because if you take longer after the graft is in, it will just be caught in fibrin and it will be difficult to unfold. So we use, I use the cannula or iris repositor to go within the scroll to reposition it in the center, and at the same time confirm the orientation, as you can see, Montsuri sign. And then after that, I put, it tends to scroll back on because it's aphakic, because it's vitrectomized eye, so there's deep AC. I was meant to put a smaller bubble here and then enlarge it, but inadvertently I got a bigger bubble. I then used the smaller bubbles here to reposition the graft. So you can see the edge of the graft is here, this crescent edge here, and it will be, with the help of the bubbles and tapping like hockey movement, it's moved more or less to a central position now. And I will use a squint hook to even reposition it to be perfectly aligned to the previous PK. So just 1 millimeter or half millimeter left. And when I move to the squint hook, that will just move it to be as central as it can be. Now it's more central. And then I accepted that and put the air bubble in. Now, regarding the post-operative complications, the most common complication after DMEK is DMEK descent membrane detachment requiring rebubbling. Sometimes your air or SF6 gas bubble escape behind the iris and lead to pushing the iris forwards, and then it can lead to peripheral anterior synechia, high pressure, as Mohamed has mentioned earlier. There is also the chance of primary graft failure. It can be due to upside down DMEK or due to poor quality tissue from the start. And finally, endothelial graft rejection. My experience with primary graft failure with DMEK, I've done about 250 cases now. None of them has been related to the material quality. It's always the upside down DMEK that causes primary failure. Because if the tissue itself is not good quality, you will notice that during preparation. You will notice a lot of staining with the vision blue, a lot of marks. It will be quite obvious. So you have to think upside down DMEK if you get a case of primary graft failure. This was one of the cases where the gas escaped behind, but the problem here was the gas escaped eventually, but the patient came back with like peripheral anterior synechia, and we had to go back in just to reform the AC. So we tried with the iris repositor to reposition the iris separated from the cornea and then reform the AC. As you can see, the cornea has cleared already because the patient was under high pressure with the bubble before this happened. So it was okay. It was good enough to stick the graft and to clear the cornea. Now, just a few tips from the literature. So whether we use SF6 or air, the literature shows equivalent effect clinically on the endothelial cell count, although the evidence is not very strong and no lab studies on this. Equal best corrected visual acuity. From my experience and from the literature, it's much better attachment and much less rebubbling rate with SF6. My standard now is to use 15% rather than 20% SF6 because it reduces the chance of rebubbling, and at the same time, it doesn't increase the risk of getting like pupillary block and high pressure. In terms of the size of the bubble, to minimize the need for rebubbling, this study was checking whether larger are always better or not. So essentially, if you have a good size PI and leave a largish bubble like 80%, whether the patient positions or not after the procedure, that reduces the risk of graft detachment. This was a case of partial graft detachment seen earlier, while there was still like 40% of the air bubble in situ. So we just got the patient to position to lie on the left side so that the air can tamponade this detached part. And as you can see here on the OCT, 3 days later, it got fully attached and the corneal thickness started to decline. This was a case of generalized detachment. So even as you can see here, all the cuts from up down, you can see that the graft is in apposition, but is not directly sticking and is not clearing the cornea. When I see this post-operatively, I always go back and review the video, and this was proven to be upside down DMEK. It was under a PK. So, and that video is actually the primary surgical video. So you can see small PK done in the past. And as you can see here, this is what I was referring to, that you can actually be deceived if you haven't got a mark and if you just follow the Montsuri sign. So you can see that the cannula is going underneath the graft and then going side to side was deceiving. And actually the graft was upside down and this needed a reorientation. And this was the OCT 1 week after reorientation of this. As you can see here, this is the graft host junction of the original PK, and you will always get some difficulty attachment around this edge, but this doesn't matter as long as the center is attached and clearing. If you are in doubt about graft orientation, then you go back, review the primary surgery video, and if you thought it's upside down, then you have to consider either reorientation if it's early on, or trying arranging a regraft. This study has shown that secondary DMEK after a failed primary DMEK would give equivalent clinical results to a primary DMEK. So you haven't lost much if you do it in a timely manner. So prompt intervention to minimize the duration of corneal edema and the risk of corneal scarring would improve the outcomes if you needed to do a secondary graft. This is just the recommended post-operative steroid regime talking about prevention of rejection. So prednisolone acetate, 1%, 2 hourly for 1 month. And then we reduce it to 4 times a day for 2 months, and then 3 times for a month, twice for a month, and then once a daily for the rest of the first year. If the patient develops like steroid response glaucoma and you want to change to FML, there is enough evidence to show that changing to FML after the first month would not affect the rejection risk as much. So the rejection risk would be like 1.4% in the first year if you change to FML, according to this study by Price et al. And this study has shown that you can actually switch to FML because the difference between the group that had prednisolone versus the group that had FML in the first year was not very relevant. So the other group has also had just below 1% risk of rejection, so is not a big difference between the two groups. Whether you will continue on steroids or you will stop it after the first year is still controversial, but the same group, Price, have compared the once-a-day steroid, FML or loteprednol or prednisolone after the first year to no steroid use at all, and the rejection was 0% after the first year in the topical steroid group to 6% in the group that discontinued the steroids. So my preference is as long as the patient can come in to our regular follow-ups to check the eye pressure, to check the optic nerve, I just keep them on once a day of the steroid drops. Once I think about discharging them, let's say 5 years down the line, I consider stopping it altogether. And this is the study that proved that the difference was from 0% to 6%. And that's it. Just heads up, we're doing this DMEK and DALK course. This is the second. We do it in Hull in the United Kingdom, and we've managed to train quite a good bunch of colleagues, over 20 colleagues, to do DMEK last year. And this year we're doing DMEK and DALK. It's on the 21st of July with help of Professor Liu, Professor Goeda, and my colleague, Miss Anand. We've got only 1 seat available on the course if anyone is interested. We have colleagues who join from Arab countries, from Libya, from Emirates. So there is only one seat available, and I would expect that to go as soon as possible. And thank you very much.
Thank you very much, Dr. Ahmed. Reserve that seat for me.
You're welcome. You be our guest, Dr. Mazen.
Thank you very much. And really, congratulations for the great work you are doing with Professor Gueda and Professor Lou. So now we can open the discussion. If you don't mind, Dr. Ahmed, to stop sharing. Yes, thank you very much. Let's take the questions of the audience first before we start the discussion, if you don't mind. What do you think, Professor Lou? Shall we take the questions first?
Yes, yes, absolutely. There are already 3 questions on the chat box.
Yes.
One is, the last one is, how do you distinguish between primary graft failure and endothelial rejection? And then there is one on blood and fibrin. And there's also another one I cannot quite remember. Oh, now there are more questions coming through. So how about if the speakers have a look and tell us? And the second question was supplemented by what are the early signs of DMEK rejection? So I think, should we take the rejection first? Because it is true that many people do not know what a DMEK graft rejection looks like. They know how a PK rejection looks like. So Ahmed, do you want to take that?
Yeah, that's fine. So the signs of rejection would always, well, it will be symptoms and signs. So for patients who have if you're suspecting rejection, that means there was a primary improvement, so initial improvement after having the DMEK done. And then there is a decline in vision. There is corneal edema. There is also sometimes like the signs of acute inflammation within the eye. So the patient may complain of ache as well. And then the signs of like AC reaction, like presence of KPs on the endothelial side of the graft. That would point more towards a rejection episode rather than a primary graft failure. And as I said, if you are not in doubt about the quality of tissue you have used, the chances of primary graft failure is very, very low. So
yes, of course. And then you have, if the patient is sensitive to light, then, that is also a symptom. And I think really in the early post-operative period, you're not really expecting a rejection, because actually rejection with the help of steroid eye drops is uncommon with DMEK. As for primary graft failure, as Ahmed said, if it doesn't work in the first few days to the first small number of weeks, then it may be upside down. Now, sometimes grafts will actually take quite some time before it clears, especially the ones which have been pre-prepared and transported over long distance. So I had one from America, which took a long time to clear. And I thought, oh my goodness, is it ever going to clear? And then it cleared, and then it stayed good afterwards. So that's the rejection. So who wants to take the blood and fibrin question in the chat box? You were talking about that, weren't you, Ahmed? So do you want to also talk about how to prevent blood and fibrin? And then if you need to use TPA, have you have any experience of that?
I've only used the TPA once, to be honest. So it's not like I think the question in the chat box is about acute fibrin reaction once the graft has been successfully inserted. Okay, so it's intraoperative rather than post-operative. Yeah, it's to be honest, I only used it once post-operatively, and it did help to clear a significant fibrinous reaction in the anterior chamber. I prepared it twice, as in asked the pharmacy to prepare it, so in case I need it during the procedure. But I was lucky, so I haven't used it in the 2 times. But there is evidence in the literature about using TPA, especially in the pediatric age group, because this is higher incidence of being pro-inflammatory, higher likelihood of fibrin release during after the graft insertion. So I think I would be willing to try it. And whenever I have a case, as I mentioned, that I am suspecting like iridocorneal endothelial syndrome or a case of post-herpetic endotheliitis where the eye is already pro-inflammatory, I order it on standby just in case, and the pharmacy is familiar of how to prepare it. And I've also got a guide if anyone is interested on how to prepare it if your pharmacy doesn't.
Oh, that's wonderful. So can I ask a question like, the sort of gas that we use? So if you use SF6, my understanding is that actually it's wonderful because the detachment rate is lower. And in fact, we know that you can even make an upside down DMEK stick. And it looks as though it's the correct orientation, and it ends up not being the correct orientation. So, I mean, there can be some disadvantages of SF6. For example, if the concentration is wrong, the pressure can go very high. And also, it is a greenhouse gas. And if you use just a little from a big canister, there's a higher risk of IOL opacification as well. So what are your thoughts on that then, Ahmed and Mohamed?
Do you want to start, Mohamed?
Yeah, okay, yeah. For me, I'm not a fan of SF6. I prefer air injection. And usually air works quite well with me. I only resort to SF6 in vitrectomized eye, those with previous trabeculectomy or previous Ahmad valve. So these are the only situations which I resort to SF6, but I don't use SF6 routinely. So I prefer just using air.
May I just ask Mohamed about
the
rebubbling
well, what
rate?
about you then, Ahmed? I think. Well, that's a very searching question, isn't it?
Roughly, what's the rebubbling rate with air?
Sorry, can you tell me this question again?
The rate of rebubbling after using air, what is it in your cases? Is it?
No, it's less than 50%.
Less than?
It's not too 50%.
50.
There you are.
Yeah, but
yeah.
Okay, so there you are. You see, so there it is. So there's this different styles here. You know, so some people will prefer to rebubble and avoid SF6 and avoid rebubbling, but I mean, Ahmed, you will agree that there are some disadvantages, aren't there, from expense to greenhouse gas to the possibility of wrong concentration. So I think, what about people's thoughts on IOL pacification? What are your thoughts, Mohamed and Ahmed?
I nearly have 4 because in Egypt the hydrophilic IOLs are more common, and some of these IOLs, many of these IOLs are not of very good quality. So I have about 4 or 5 cases of which I operated upon for pseudophakic bullous keratopathy. So I'm not the one who put the IOL, and I didn't know the type of IOL. And had IOL opacification. Luckily, the vision is not less than 0.4 or 0.5, but still, I'm not happy when I see these patients and finding these opacifications.
So
very site is it? Yeah. Go on then, Ahmed. You carry on.
My opinion is quite different. So essentially, I used to use air, and I audited the results, and like 35 or 36% of the cases needed rebubbling. Half of them may have, or 10% may twice rebubbling. Since I started SF6, I was auditing the results of the last 100 case, and actually the cases that needed rebubbling, 3 of them. So it's tremendous reduction. Yes, there can be an error. This is why we stopped using 20 in terms of the concentration to avoid that error and going into the expansile range. So we keep it 15% just to account for that possibility. I haven't seen any case of IOL opacification, but the follow-up is So it's like 2-year follow-up. So it's not long enough, but I would think with the good quality hydrophobic IOLs that we're using now.
Okay, so yeah.
And also when you look in the literature, the poor quality IOLs, they actually get opacified even with air. So not necessarily SF6.
Oh, for sure. Yeah, you're right. Air is no protection. It's the contact with air and SF6. And the other thing is, of course, I mean, hydrophilic will be better than hydrophobic. Sorry, the other way, hydrophobic will be better than hydrophilic, but even hydrophobic can also opacify.
Yeah.
Okay, so we're getting towards 7:45 now in the UK. So are there any more questions in the chat box? And Professor Sinjab, do you have any areas that you feel that we haven't covered and that you wish us to cover now?
Thank you very much. No, I think that was wonderful, and this is more than enough. Thank you.
All right. Well, thank you, everybody.
Yeah,
it's been wonderful.
Yeah, thank you very much, and I'd like to thank you all for being with us, and have a great evening, Professor Lou, and hope to see you in more sessions in the future. Thank you very much, Professor Guida. Thank you very much, Mr. Ahmad, and thanks to the audience as well. And have a great evening and goodbye. Assalamu alaikum.
Alaikum assalam. Goodbye.
Salam alaikum. Bye-bye.
Alaikum assalam. Goodbye.